Welcome, everyone. Thank you for taking time out of your busy schedules to join us for today's webinar, Lessons Learned about Human Fallibility, System Design, and Justice in the Aftermath of a Fatal Medication Error. I'm Judy Smetzer, a nurse working with the Institute for Safe Medication Practices on publications, particularly the Ismp newsletters. I'll be your host for today's webinar. Today, our speakers are going to provide you with an analysis of a 2017 fatal medication error with a neuromuscular blocking agent that led to the tragic death of Charlene Murphy, the firing of the nurse who made the error, Redonda Voigt, the loss of her professional license in the state of Tennessee, and the criminal prosecution and guilty verdict against Redonda for criminally negligent homicide and gross neglect of an impaired adult. So it looks like from our initial polling question that more than 91% of attendees today are already familiar with the case. I'd like to next cover a couple quick housekeeping items. I want to remind you that the webinar is being recorded and it will be available on the Ismp website, and there'll also be a link to the recording on the Just Culture Company website. Handouts for today's program can be found using the link provided in the reminder email you received earlier today, as well as in the Zoom chat box. All the webinar attendees will be in the listening mode only during the presentation, but I want you to feel free to ask questions during the program by accessing the Q&A functionality on your toolbar at the bottom of your screen. If the speaker doesn't address your question during the program, we'll have time at the end of the webinar for questions and answers. Next slide. Before we start, let me introduce our faculty. We have 3 speakers today who will be using their knowledge of medication safety and justice to describe the circumstances that led to the fatal medication error, how you can prevent a similar tragedy at your practice site, and how you can apply the principles of a just culture to achieve fair and balanced accountability in your workplace. Our first speaker is Barbara Olson, a nurse and senior advisor for the Just Culture Company. In this capacity, she supports healthcare clients in planning and sustaining just culture as a system of workplace justice. Barbara is well known to ISMP as she completed a 1-year fellowship in 2008 with us. Before joining the Just Culture Company in 2019, Barb held corporate patient safety positions with HCA Healthcare and LifePoint Health. Barb will open our webinar by setting the stage and telling the story of the fatal medication error. She will identify many of the contributing factors that led to the error and describe downstream points in the medication use process where the drug selection error might have been captured. Our next speaker will be Mike Cohen, founder and president emeritus at ISMP and a consultant to the U.S. Food and Drug Administration. Dr. Cohen founded ISMP in 1994 and launched the first of the 5 ISMP Medication Safety Alert publications in 1997. Mike has been recognized over the years for his advocacy, contribution, and understanding of medication safety, including being recognized as a MacArthur Fellow in 2006. Mike will describe the relative fitness and reliability of the medication use system that Redonda Voigt worked in when she made the error, touching upon upstream strategies that might have prevented the error, as well as downstream interventions associated with reducing the risk of neuromuscular blocking agents reaching the patient. Mike will also share his perspective on the fallacy of holding Redonda Voigt and other nurses individually responsible for following the 5 rights of medication use. Our final speaker today is David Marks, CEO of the Just Culture Company. David has both a bachelor's degree in mechanical systems engineering and a JD in law. He started his career as an aircraft design engineer and then later launched a research consulting practice focused on the management of human error through the integration of systems engineering, human factors, and the law. David is an expert on just culture and has also developed risk modeling methods, including an approach called socio-technical probabilistic risk assessment, we call that STPRA, as well as the trajectories process. These processes have been used to model and quantify the risks associated with aviation, space, rail, and healthcare. Today, David's going to be talking about justice and learning. He will pose the questions such as, was the firing of Redonda Voigt fair and just? Should all employees who are not procedurally compliant be fired? And are patients safer because Redonda Voigt is no longer working as a nurse? He will describe the just culture model of accountability, clarify the fundamental disconnect between human error, at-risk behavior, and negligence, and describe what leaders can do to prevent similar tragedies and adopt a fair and just culture. Barb, I'm going to turn the webinar over to you.
Thank you, Judy. So as you pointed out, people want to understand this case because they care about justice and they care about learning how to prevent tragic outcomes like the one we're going to talk about today. Those of us who tell the story, who hope to create ahas and drive meaningful action, have a heavy responsibility. So as we begin today, I want to start by acknowledging the sorrow we feel for Charlene Murphy, who lost her life in a tragic constellation of events, and also acknowledge the loss experienced by Mrs. Murphy's family, friends, and her community. Next slide. I'm going to move our conversation forward this afternoon. Telling this story is revealed through publicly available sources and artifacts. These include reports of interviews with Redonda Voigt and other staff that appear in a November 2018 CMS report. We've also reviewed testimony given under oath by Redonda Voigt and other nurses involved in Ms. Murphy's care before the Tennessee Board of Nursing. Vanderbilt University Medical Center Medication Safety Program Director is also on record in this testimony, as are recounts of interviews with Redonda by the State Department of Health investigators. Much of what is known about the sequence of events that resulted in Charlene Murphy's death comes from the narrative provided by the nurse who made the original error. It is important to recognize that Redonda Voigt is a nurse who told what she knew as soon as she knew it to any stakeholder for any purpose, in hopes that understanding her actions, her state of mind, her priorities, her omissions and flaws could help her patient or any other. From a place of personal accountability and commitment to system improvement, Redonda's conduct in the aftermath of this event is what the patient safety community has longed for, indeed has spent 2.5 decades nurturing. Let's also note here that 7 days after Charlene Murphy's death, Redonda Voigt is fired, with her employer citing her failure to adhere to the 5 rights of medication administration. In July 2021, the Tennessee Board of Nursing revoked Redonda's license, and on March 25th, 2022, she was convicted on 2 felony counts. She'll be sentenced on May 13th in Davidson County, Tennessee, and could serve up to 12 years in prison. So as we consider the events that transpired on the day after Christmas in 2017, during this webinar, we're going to strive to walk in the shoes of Redonda Voigt. We also need to acknowledge the absence of the actual root cause analysis and the possibility of flaws in this stories that we can reconstruct, especially those arising from things we would need to know, but do not know. Next slide. But let's also lean in and consider what a good root cause analysis would reveal. What more we would need to know about Redonda's decision-making and the decision-making of her peers. Beyond what we can identify as tangible actions, we want to appreciate what made sense to Redonda at the time, what she perceived as normal and what she perceived as risky. In just culture, we do not judge individuals relative to an aspirational standard like that of a nursing textbook. We judge errors and choices contextually, considering competing priorities and individuals' conduct and risk tolerance relative to what others in similar situations would do. The sweet spot for improvement is deeply understanding where choices are suboptimal and unacceptable, but where they may make sense to workers because they're seen as necessary, justifiable, or not seen at all because they're habituated. We call these behaviors at risk. Suboptimal practice does not become a new standard of care in a just culture. Rather, in dealing with at-risk behavior, we pave the way for organizations to proactively consider and manage the silent threats to safety, to talk about workarounds, production pressures, cognitive lapses, bad habits, and other elephants in the room. In just culture, we reserve disciplinary sanctions for recklessness, acts in which people consciously disregard substantial and unjustifiable risks. So as we examine this next set of slides, we're going to take a look at the tragic events. The specific event that will take Charlene Murphy's life is tied to a wrong drug medication error. But the circumstances, the forces, the parallel priorities that contributed begin upstream. So we're going to start with an understanding of the way care was organized and delivered in the neuro ICU step-down unit where Charlene Murphy received her care, how the unit manages its day-to-day mission of caring for patients, and how the unit brings along its next generation of nurses. Redonda was engaged in both of these priorities on the day of the fatal medication error. There's a few things you should know to appreciate this case. The neuro ICU designates a nurse called a help all nurse to assist other nurses in moving planned care forward. Redonda was the designated help all nurse on the day of this event. She's not a general house-wide float nurse, but an RN member of the neuro ICU team. We've learned there was no unique job description for the help all nurse. The expectation appears to be that these nurses will perform tasks, leveraging their skills and competencies across a wide array of care settings for patients with neurological needs. Redonda is also assigned as the preceptor of a new graduate RN. It may be helpful to know that the orientee had requested Redonda as his preceptor based upon his positive experience working with her and her passion for nursing. And it's probably safe to infer that in selecting Redonda to serve as the preceptor for a new graduate, she's someone who's seen as clinically competent, a good role model, and that her conduct aligns with what her organization and her unit values. Redonda and her orientee were preparing to go to the emergency department to perform a swallowing study immediately before she is tapped by a colleague to help provide care to Ms. Murphy. And you can move to the next slide. So we're going to take a quick minute to consider the circumstances that gave rise to the need for the medication and the just-in-time planning that occurred to carry out this order. Ms. Murphy was admitted to the hospital with a diagnosis of cerebral hematoma on Christmas Eve. She had required an anti-anxiety medication for an MRI performed on that day. She was improving and transferred to a regular patient floor was anticipated following her PET scan on December 26th. The need for Ms. Murphy to have her anxiety managed during the PET scan was not anticipated. This created an urgency when it was discovered after Ms. Murphy's arrival in radiology. A radiology team member alerted the primary nurse in the neuro ICU of Ms. Murphy's need for anxiolysis, and a provider's order for midazolam was secured. This order was entered electronically and accurately. Something we'd like to know more about, especially as it relates to system improvement, is how the care team screened patients for the possibility of anxiety inside of a closed tube, which is a condition that could be reasonably anticipated and managed proactively. And perhaps we'd like to know why IV medications for anxiety were selected over other routes that are less invasive, like oral agents. So you can move us forward there. So now let's consider the adaptive care planning that occurred. The schedule in radiology was too busy for one of the radiology team RNs to administer the ordered medication. Mrs. Murphy's primary nurse also could not go, thus sought task assistance from the help all nurse to prevent the case from being canceled. We don't know if the ordered medication was displayed in the electronic health record as the generic midazolam or by its common trade name Versed. We do know, though, that the name of the drug ordered for Ms. Murphy was communicated verbally between the primary nurse and Redonda bot as Versed. Neither the primary nurse nor Redonda routinely administer Versed. Both testified that patients in the neuro ICU infrequently receive drugs that alter their sensorium. It is at this time that the need for patient monitoring is first considered. The initial discussion between the primary nurse and the radiology technologist. The primary nurse concludes that monitoring was not indicated, noting that orders for telemetry monitoring had been discontinued and he had ordered a non-clinical transport for Ms. Murphy when she went to the radiology unit. Patient monitoring was also discussed by the primary nurse and Redonda with the same conclusion. At no time did Redonda plan to provide monitoring to Ms. Murphy. So here's where we'd like to know more about the operative definition of monitoring in the minds of the neuro-ICU nurses, especially those who administer medications outside of the neuro-ICU. We'd want to know how or if this type of monitoring differed from the monitoring that would have been provided by RNs who work in the radiology department. We wonder about the possibility that some number of neuro-ICU RNs did not share a mental model about the need, type, and feasibility of medication monitoring that can and should occur in the radiology department. In our event investigation, we would also want to examine the medical records of other patients who received IV anxiolysis by a help all nurse in radiology in the fourth quarter of 2017. This would allow us to understand norms and what risks similarly qualified nurses perceived relative to patient monitoring following medication administration, and also something about how the organization managed those associated risks. We'll also note at this time that CMS cites Vanderbilt for failure to include guidance about the nature and frequency of patient monitoring for Versed or any other drug in the organization's general and high alert drug administration policies. Now let's turn to the automated dispensing cabinet in the neuro-ICU, where Rhonda will procure Ms. Murphy's medication. Recognizing that many people following this case and here with us today may not be clinical subject matter experts, I'm going to take just a minute and describe a little bit about how the medication use system in acute care is designed and the safety features this system confers to patients and clinicians. Keep in mind, these processes leverage software and require interfaces and communication between systems produced by different vendors. First, physician orders are entered into a specific patient's electronic health record. Next, the orders pass to a registered pharmacist who reviews the order, checking the dosage relative to the patient's age, weight, and health status. After pharmacy performs this double check, the order passes to the patient's profile in the automated dispensing cabinet, signaling the order for a particular drug is now available, good to go for a specific patient. The approved medication then appears on the patient's profile and is visible to the nurse, who will then procure the ordered drug for the patient. When the system works as designed, profiling drugs helps to constrain drugs in the cabinet, making only those ordered by a physician and reviewed by a pharmacist available for a specific patient. At times, however, changes in patient condition may require nurses to remove drugs in order to meet time-sensitive patient needs. When this need occurs, nurses use an override function in order to secure medications timely. Organizations generally define these circumstances and conditions in policy, noting the level or type of urgency that would be necessary to forego the safety checks and wrong drug prevention efforts that pharmacy review and profiling confer. Next, let's consider what we know about this process and how it worked in the neuro-ICU on December 26th, again, drawing on the testimony of Redonda and the organization's Medication Safety Program Director before the Tennessee Board of Nursing. Recall it's at this point that Redonda will procure the medication for Ms. Murphy. Redonda remembered the timeliness of pharmacy review as being unpredictable following an interface change between the electronic health record and the automated dispensing cabinet a month prior, November of 2017. She recalls emails supporting use of override to assure timely patient care. And she went on to note that Ms. Murphy had received over 20 drugs via override during her 2-day stay in the neuro-ICU. When Redonda does not see the drug Versed on Ms. Murphy's ADC profile, she concludes pharmacy review of Ms. Murphy's anxiolytic will not occur timely. Tragically, the ordered medication has been reviewed timely. This is a good thing. The tragedy, though, is coming. It appears on Ms. Murphy's profile using its generic name, midazolam, working as designed. However, Redonda does not know that midazolam is the generic name of Versed. She elects to use the automated dispensing cabinet's override function to secure the ordered drug. So now, as we look at drug procurement, it is important to know that Redonda's preceptee is present as she begins to interact with the screens at the automated dispensing cabinet. The pair had been discussing the upcoming swallowing study, which they're preparing to conduct in the ED. Redonda testified that this conversation continued while she was at the ADC and interacting with the screens. So at this point, we would want to know more about the practice norms of Redonda and other neuro-ICU nurses at the automated dispensing cabinet. Is this considered a protected, distraction-free zone, something akin to the sterile cockpit in commercial aviation? Or are nurses on this unit expected to manage multiple tasks simultaneously, perhaps receiving phone calls from physicians or answering questions from their colleagues while they're at the automated dispensing cabinet? Simply stated, we want to know if Redonda's practice was different from her normal practice on that day, and if her perception of the risks of distraction at the ADC were different from others. So at the dispensing cabinet, Redonda types in VE. Vecuronium appears at the top of the pick list, and she selects it. She interacts with standard warnings that present for any drug removed on override. We should note here that vecuronium, a paralytic that will cause grave harm if it is administered in error, was not constrained nor differentiated from other vials in the automated dispensing cabinet, and it was available on override. The drawer and storage bin where vecuronium was stored is accessible with the same keystrokes used to procure medications routinely given on override on the unit. The screens on that day did not call out any warnings specific to safe and intended use of a paralytic. The Institution for Safe Medication Practices had published strategies for constraining and differentiating paralytics in automated dispensing cabinets in 2016, based on reports of inadvertent administration of these paralyzing agents in other critical care settings. On the 26th, Redonda removes vecuronium from the dispensing cabinet bin, believing she has retrieved the intended drug Versed. It is at this point the error that will claim Ms. Murphy's life is set in motion. All other activities, self-checks on the part of Redonda, and any processes built into the medication use system are now in place to detect and correct the error before it can reach the patient and cause harm. You'll see these flagged with little orange magnifying glasses as we walk through the remaining events. David and I will return to these opportunities or defenses later when we talk about the strength, robustness, and quantification of system design. One thing to consider as we continue to walk through this case, though, is that our ability to detect and correct our own errors is limited, especially when a learned behavior becomes automatic. So upon retrieval, Redonda notes powdered formulation. She remembers flipping the vial and reading the reconstitution directions on the back of the label. She does not read the label on the front of the vial. In our investigation, we'd want to know more about Redonda's practices and how the organization manages the possibility that nurses might not look at the label each and every time a drug is procured from a dispensing cabinet. We want to know, is Redonda a gross outlier, ignoring risks visible to and motivating her peers to act differently? Or is it possible that she and maybe others might have drifted into an unsafe practice habit? We'd look for the results of any behavior-based observation programs, and also at the neuro-ICU's automated reports that indicate how often wrong drug errors are detected by barcode scanning technology at the point of administration. So Redonda gathers the supplies she'll need to administer the drug, and with her orientee, heads to the radiology area where she had never been before. Once in radiology, Redonda locates and identifies Ms. Murphy in the radiology corridor. She attempts to locate an electronic health record terminal and barcode scanning technology and learns from the radiology tech these are not available in the radiology suite. Redonda will later testify that barcode scanning is part of her routine practice in the neuro ICU and sought it out purposefully in the radiology area. She does not recall reading the drug name nor appreciating any warnings on the vial label. She reconstitutes the medication and administers the drug to Ms. Murphy's central line while in the radiology hallway. A radiology tech is present during drug administration. Redonda plans to document both administration and narcotic wastage in the EHR upon return to the neuro ICU. Our investigation would seek to understand more from the perspective of the radiology tech. While this individual is in no way responsible for Redonda Bott's nursing practice, it doesn't appear the radiology tech voiced any concern with the way Ms. Murphy's care was unfolding. When people speak up to share a concern or note a deviation from anticipated care, this creates yet another opportunity to detect and correct an upstream error before it reaches the patient. We would want to know if the radiology tech didn't feel safe to speak up about this practice, or if they simply didn't perceive that Redonda's practice was unusual relative to what normally occurred or what they thought should occur. And finally, we'll consider the event that transpired in Ms. Murphy's final hours, and what more we'd like to know as we consider the way care is organized and delivered in the radiology suite. Recall here that Redonda is not familiar with radiology norms, flow, or the competing priorities behind the doors of the radiology suite. She and her orientee proceed to the ED as planned, leaving Ms. Murphy with a radiology tech who takes her to a holding area inside of the radiology suite where Ms. Murphy will await her PET scan. This area is equipped with a surveillance camera. We don't know if clinical monitoring equipment is present or how others who provide post-medication monitoring to their patients in this area access equipment and do that monitoring. Post-administration drug monitoring for Ms. Murphy does not occur, and she is discovered unresponsive approximately 25 minutes later. She undergoes resuscitation but experiences brain damage such that supportive care is withdrawn and she passes away the next day. So I invite you to continue to reflect, to consider what you now know and what more you'd like to know as I hand over to Mike Cohen. Mike is going to talk about opportunities to improve medication safety through better system design.
Well, thanks so much, Barb. Really appreciate that review. And like you, on behalf of myself and the staff at Ismp, I do want to start off by expressing our condolences to the family of Charlene Murphy as well. It was really a horrible situation that the family had to go through, and I know that people who do know about your family's tragedy feel the same way that I do, and as our staff does. I also wanted to bring greetings from Dr. Rita Jew, ISMP president. It was really Rita and one or two others that on our staff began to interact and talk about the idea of doing this webinar right around the time of the trial and the jury verdict. So thank you, Rita, for bringing that suggestion to us, and appreciate making sure that this happens. So thank you for that. And I also wanted to thank all of you for joining us today. I don't know if you see it on the screen there, but we have thousands of people on this call that are connected, and they're not just from the United States either, they're from all over the world. So that's really a tremendous thing to know. Thank you all for doing that. I do want to go on and talk about some of the opportunities for improvement that have come out of this situation. And may I have the next slide? I'm sorry, the previous slide, please. Jordan. Okay. Actually, there we go. Okay. Next slide. And the next slide. I'm sorry, I clicked on the wrong slides. I had my own slides on the desktop as well, and clicked on that. I did want to bring up an article that we did just recently. If you haven't seen this, I did want to say that my colleague Judy Smetzer, who's moderating this, I think she did a masterful job working with our team at ISMP and pulling together a critique of the trial itself. We really wish the jury had been given more information about the system-based safety issues that were really beyond the control of that one individual nurse, Redonda Vaughn. We're going to mention some of these today, but for those of you who haven't read this article, it's a gem, I think. And I know not everyone agrees with it, but this is fact. We've been doing this work for many, many years. We've been to hospitals all over the country where similar errors have taken place and have developed an expertise in doing an analysis of events like this. And that's what's going into putting this article together, in the hopes that people would understand that this isn't just an error by one nurse. And this isn't something that happened at one hospital. Judy and I go back to the 1990s when I was chair of the United States Pharmacopoeia's Medication Errors Committee. And the first thing that we looked at was errors with neuromuscular blockers. And we came up with the idea of having the warning paralyzing agent on the cap. And why is that there? We know that that isn't going to get read 100% of the time, but it is educational, and it does sometimes serve as a stopgap. Some people do see it and realize that it is a paralyzing agent, but not everyone does. And I want to talk about that as we go forward this afternoon as well. But at any rate, we want to mention some of these safety issues, and I do hope that you'll take the time, to link to that link we have there at the bottom of the screen, so that you have a better understanding of all that the jury missed. And that's sad, I'm afraid. Next slide, please. I do want to mention again to those of you that aren't familiar with ISMP, we're a nonprofit organization. We've been around, we were founded in the mid-1990s. We are 501c3, self-sufficient. We operate the National Medication Errors Reporting Program, and we have a memorandum of understanding with the Food and Drug Administration so that everything that we receive is redacted and passed on to FDA for their adverse event reporting system. We meet with FDA on a regular basis. We talk about not just these types of errors, these product safety errors, but preventive measures as well. And also, many of you may not realize that the United States Pharmacopoeia has a nomenclature and labeling committee that can set standards, does set standards, including for the neuromuscular blockers, as I just mentioned, but for many other drugs as well, that FDA actually has to follow, unless they have a good reason for not doing it, which is a pretty rare situation. So we operate 3 reporting programs, and we use the information that we get from you, the reporters. And I know many of us are concerned that we might see a reduction in the number of reports that come to ISMP and FDA. And we hope that doesn't happen, obviously. We need you to continue doing what you've always done in the past. We receive the reports, we investigate them, we write about them in our newsletter, and we come up with preventive measures that I'm going to talk about next. And many of these have been implemented on a high level, like the Joint Commission or the Food and Drug Administration, or USP, or companies that take this very seriously and don't want to see their products misused. And they've improved their labeling. And our vendors of medical devices, we're going to be talking about automated dispensing cabinets. Our vendors have learned so much in the area of safety with the automated dispensing cabinets that, these are not your father's ADCs. These are much safer than when we first started with automated dispensing cabinets, and most hospitals use them today. And we are at a level of software now. We're able to do a number of things that we weren't able to do before. We're able to protect against some of these issues. The problem is, it isn't always done. It isn't always utilized. We're not keeping up to date necessarily with the software or with the cabinetry itself. And unfortunately, some of these upstream efforts that I want to talk about And what I'm talking about here is things that you could do before anyone even goes to the cabinet and removes the wrong item. And I think the more things that you can put in place and layer, no individual recommendation that I have is going to be enough to prevent an error 100% of the time. But when you layer them together and you consider how they need to be implemented in advance, upstream, I think you have a very, very good chance of preventing a situation like we saw here that has happened so many times before the Vanderbilt situation. And sadly, so many times even since we've had reports of these errors. So not only that, but many of you don't even know that we have even had the same exact error reported where somebody typed in VE for Versed and out came Vecuronium. I'll talk about that in a minute as well. So yeah, this is what we need to do. And then I'm going to talk about some of the downstream requirements that we need to have in place as well. So let's go ahead and do that. Let me have the next slide. And I do want to mention on the next slide that we originally, we've written about neuromuscular blocker errors, many other drugs and drug categories that we consider high alert, like insulin and opioids and so on and so forth, that you know very well. The Joint Commission requires that you take a look and have a list of high alert drugs. Anyway, we wrote about this in 2016. Next slide, please. And I want to take some of the items that we wrote about then and talk to you about them today. And on the next slide, as you can see, in 2018 or 2019, more recently after the incident, we wrote again about safety enhancements that every hospital needs in place. Both of these articles that we wrote are freely available on the ismp.org website, and you can see the link at the bottom of the screen that you will be able to type in or click on to actually get to the article. Many people have asked us since the verdict, do you have a list of things that we should be doing in our hospital that we should consider to implement to prevent errors with neuromuscular blockers? And that's exactly what I'm going to be providing you right now over the next 10 or 15 minutes. Next slide. And many of these come right out of these two newsletter articles. As a matter of fact, there's probably a little more detail. We don't have time to go over everything that was in these first two articles, or these two articles that we did. So if you haven't done so already, please go to them and make sure that your safety committee, your P&T committee gets together on a multidisciplinary level, physicians, nurses, pharmacists, like we have at ISMP, and you go through this and say, you know, these are recommendations that are coming from a national safety organization, and we work in conjunction with other groups like the Institute for Healthcare Improvement, for example, the Joint Commission, and there's a lot of back and forth that we have. And we have advisory boards that are out there in the field every day taking care of patients that give us feedback on these as well. You know, some of them even have an evidence base in the literature. They've been studied perhaps, but most have not. But we still put these together for your consideration. So please do take a look at these. So I do want to say, make no mistake, this could happen at your hospital, you know, and that's why you need to do this. It's crucial to take these steps. And we've seen many of these same safety vulnerabilities when we go out on, you know, to visit a hospital, either after there's been an incident or, you know, to have us look at their medication system and give them recommendations. That's something that we offer. Next slide, please. We have recommendations for providers that I want to give you, and these are upstream again, before there's even the opportunity of removing the wrong drug. First of all, you know, Barb mentioned a few times that the name Versed was typed in. Do you know that that was actually discontinued in the early 2000s? The manufacturer Roche retired that name, yet we still use it. Not only that, but do you know the drug information vendors that supply the databases of drug names for our major systems actually still have that drug, or some of them do anyway, listed in the database so that your system may be populated with that name. So we need to do a better job at the drug information vendor level and we're going to be communicating with them. And we also need to do that locally. No one should be, it's midazolam. Versed is not on the market. And there are probably other brand names that have been retired that are still in common use. And, you know, that's the first thing that Redonda was presented with when she went to remove Versed and typed in the first two letter characters and got the vecuronium instead. And Barb mentioned that she may not have been familiar with the generic name for Versed and maybe thought, I don't know that for a fact, but maybe thought vecuronium was the generic name. I just don't know. I didn't see that written anywhere. Anyway, that's the second thing. So I hope you will look to see whether Versed can be ordered at all. It's time to retire that. It really is. We're talking a lot of years, 17 years, 19 years later. So the second thing, ADC order entry on override. We know that override is going to be utilized, and I'll talk about that in a minute as well. It's going to happen. This is nothing, there's nothing wrong with doing that, especially when you have situations where the drug cannot be properly reviewed by a pharmacist in advance. There's some, you know, constraints that need to put into that that I'm going to talk about in a minute. But again, you know, we want to see more letter characters than two. There's lots of names that will come up if you type V. There are lots of names that will come up if you type BE. And I could go on and on. You know, there are many drug errors that have happened. In fact, I worry very much that, you know, when we're typing in the first 2 or 3 letter characters, we see 2 or 3 different names on the screen, and we are probably selecting drug errors at a rate that probably exceeds the handwriting problem that we had in the past. And I'm not kidding. We get more errors with MET 500, which is metronidazole or metformin 500 milligram. And many others like that too. I'm going to show you a list that was just published in one of the news media reports that was done by Brett Kelman from Kaiser Health News. Anyway, we want to see you, you know, individually, as well as a hospital effort and a cabinet effort. We've interacted with the major vendors of the cabinets, and both of them have agreed to provide software that would require a certain number of letter characters. That's great when typing in orders on override. Not everything, but on override. So, and by the way, here's another one that we just had reported very recently. Somebody typed in RO for Rocephin, and out pops rocuronium, another neuromuscular blocking agent. So I don't know if the jury knew about all these kinds of things, but I wish they would have. That's my point here. Next slide. And also that you recognize this as well. These are some of the ones that Mr. Kelman had in his articles. So, you know, I thought this was a really interesting slide. And one that we just ran in our last newsletter was PIT. That has been mixed up for years. Somebody says a PIT drip, and there's always an inexperienced pharmacist or nurse that thinks it's Pitressin when they really mean Pitocin, or Pitocin when they really mean Pitressin. So these are just a handful of the ones that we have actually had happen. So this is a very, very common type of mistake that is going on now around the country. And it wouldn't happen if we used 4 or 5 letter characters. And thank you to the vendors. They're making this software available. Next slide, please. I do want to tell you that we recently published an article. There's a potential unintended consequences. If you misspell a name or you don't know that there's a dash like IV-fat, you're not going to be able to pull that drug up. We did have an incident with Epi, for example, and we did write about that, and the link to the possible challenges with the 5-letter characters is at the bottom of the screen on this article too. But I do want you to know that we've been interacting, we've seen interaction rather with hospitals that have already implemented this, and it does take a little getting used to, but it's certainly safer, and I think people appreciate the need to do this. Next slide, please. I want to report on something else as well. Now you can see right there, almost in the middle of the slide, the paralyzing agent caps, and many of them are red, and they say warning paralyzing agent. And we know, and it was repeated multiple times during the trial, which I listened to a good part of it. And one of our nurses, Jen Gold, listened to the whole thing and reported back to us. That was overseen. It was repeated multiple times to the jury that the nurse didn't read the label and da. I can't even begin to tell you how many cases there are out there where people just blew right by this. They're looking at something else. They're distracted. They're doing what nurses and pharmacists sometimes run into. 99.9% of the time, there's not an error. Unfortunately, we do occasionally run into these. So I think you need to realize that you need to do more than just rely on label warnings. And I put potassium chloride there as a good example. So potassium chloride concentrate injection was around for many years, and God knows how many people were killed when it was mixed up with sodium chloride, even diluting infants' ampicillin injection with sodium chloride. It was supposed to be sodium chloride, was potassium chloride. And unfortunately, there were multiple deaths. And the USP said, let's put a black cap on these vials. It's the only drug that has a black cap. And let's require must be diluted in a contrasting color. And that was done. And there's a whole tray of them. And we know that. And yet there were, just like with the neuromuscular blockers, still some incidents. So what happened? The Joint Commission listened. We said, we had many articles out there already. We said, somebody needs to say, what in the heck are we doing with potassium chloride concentrate on nursing units? Why do we leave nurses in a position of, God forbid, pulling up the wrong item and injecting somebody directly with concentrated KCl and killing them? And it burns, and KCl in 500 ml burns. So what I'm getting at here is, do not rely on these labels. You need barriers like the Joint Commission requires of hospitals. We had scores of errors before. It was the most frequent kind of drug error that the Joint Commission got in their Sentinel Event Alert reporting program when they started it. We have only had one incident, and that was in a non-accredited hospital since Joint Commission implemented that change. Why? Because it is no longer on nursing units. And if by any chance your nursing unit somehow has a vial, please get rid of it. So let's get back to this slide. Eliminate the storage of neuromuscular blockers where they're not routinely needed. Yes, we can find them on medicine units. Why? Limit the use of neuromuscular blockers, the storage rather. That alone can serve as a barrier and help reduce the potential for mix-ups. We know that it's needed in ICUs. We know it's needed in the emergency room and certainly in perioperative areas. But it could also be provided in a Ziploc bag with warnings all over it. It could be sent by pharmacy when needed if it's a non-ICU area. It could be provided in a sealed box. It could be provided in a rapid sequence intubation kit. There are other things that you could do to store in your automated dispensing cabinet, for example, if you have to have it. Anyway, please consider that. It isn't done in too many hospitals. Also, some of the cabinets, you're able to actually enable a block load so that nobody puts the neuromuscular blocker or a drug from that class into one of the cabinets. So it can't be put in there and appear on the screen. So that I think is really important. Next slide. So I think you do need to consider this hierarchy of error prevention strategies. This is a really good one that we put together several years ago. We just revised it within the last month, actually. It's nice to tell people to be more careful, that and, a dime is not going to get you on the Philadelphia subway. Available information, providing that's a next step up. That's important. Education is important. But as you can see, as you go up this model, the least effective strategies are on the bottom. Rules, policies. That's what the jury heard. Lots of rules, lots of policies. That is not enough. You need forcing functions at the top. You need barriers. You need automation and computerization and standardization as we go down. So look over this slide and think about it as you implement these strategies. Next slide. What else? Well, I really think, there was a lot of confusion about the monitoring, the patient monitoring process there and handoffs that occurred. It was requested that the nurse, or Donda, as it turned out, was supposed to come down and monitor the patient, but I'm not sure that, that was well communicated. And why didn't the area where the patient was in a holding area have monitoring process? So we think in all areas, if you're going to be giving an anxiolytic or a sedative, first of all, start off with an oral drug. Why would you go right to an IV drug called Versed? That would be rule number one. So that probably should be built into your process, by the way. But you need to be prepared for this from the monitoring point of view as well. So include patient monitoring requirements wherever drugs are administered, especially intravenously. And it could be a sedative. I realize this was an anxiolytic in this case, not a sedative, but you need it for any IV midazolam or IV other type of benzodiazepine. Some level of monitoring is needed regardless of the indication. Hospital procedures should specify that monitoring and maybe consider pulse oximetry, which would alert people. You can't just do visual monitoring on a TV monitor. Other means of evaluating the adequacy of ventilation are important. And when can you stop the monitor? That needs to be in your policy as well. And I'm sure there are hospitals out there that have detailed policies, even in the radiology department. And I'm sure that's taken place now in hospitals where there have been these events. Monitoring requirements should be approved by anesthesia. They're the experts, and they can help you standardize what is needed in these cases. Next slide, please. I do want to point out that you need to affix warnings. They need to be on all the storage locations. That goes for pharmacy as well. I think these should not be commingled with other stock. I think they should be stored separately, whether it's a refrigeration drug or elsewhere. I think in the ADC itself, in the pockets, hopefully you have a cover over that, lid that contain neuromuscular blockers. They clearly need to warn of respiratory paralysis possibly occurring. And there's a warning that's on the vial label. So I think that's needed. By the way, the new warnings, they're on the back of the vial. It does say paralyzing agent on the front, but you have to turn the vial around. I don't know how many people are going to do that. So I don't think that was a good design for the warnings. That's been about a year and a half now. Visible when the ADC is opened. I think you should consider the shrink wrap that you see there on the right, which totally covers the vials of neuromuscular blockers. You have to literally peel them off. I think this is a higher level than just relying on the label itself. I think there are ways to build interactive ADC warnings so that when you go to the cabinet, you do need to select the purpose and document that. And other shouldn't be one of the choices, and it should be verified that the patient is manually or mechanically ventilated. In most ADC systems, this type of warning is configurable by medication. So in some systems, it is by cabinet. Next slide, please. And clarifying override policies. I know we talked about that a little. Of course, you want to have pharmacy verify. You want to have enough pharmacists to be able to verify and do it in a way that's not going to take too long so that the nurses are forced to get something for a patient when they need to get their patient taken care of. Leadership out there. You need to participate in the safety evaluation process in your hospital. What is needed to make sure that we get the right drugs at the right time to the patients now that we're using automated dispensing cabinets? So review the hospital's ADC override policy, confirm its permitted use and that it's limited to emergencies only, and manage that override list as well. That's really important. And then finally on the slide, educate staff. They need to know how to select drugs by both brand and generic names. If you can get them to both appear on the screen, vendors, great. If your software allows that, great. That would be of help here. That would have been of help here. Teaching practitioners to access and remove medications in profile mode. That means that the patient's meds by name are on the screen for that patient. There's no required to override, no requirement. There's no typing in letter characters. You just select right off the screen. So if something is on the screen, and apparently it wasn't here, or it wasn't utilized, then that's what you need to do to get that going. That's something you need to look into, and teaching people how to toggle back and forth. Next slide, please. And then finally, we do have targeted medication safety best practices that we just implemented this year. And best practice 18 does consist of implementing barcode scanning throughout the organization wherever meds are given. That includes radiology, the cath labs, procedure rooms. It's time to do that, not just the bedside, inpatient bedside. And please do consider this. And that's for vaccine administration too, by the way. Next slide. And now some downstream, implementing barcode scanning verification in all areas. I just mentioned that. And I think, getting ready for the future, we're going to be seeing radio frequency ID uses for individual drugs. Right now, we're using it in inventories. Pay attention to this. Start to implement RFID for inventory purposes right now where it's available, but in the future, we'll have it available for individual drugs. Work against these unjustifiable overrides. Yes, you may need a neuromuscular blocker for emergency intubation, but each override should be situation dependent and justifiable. And then finally, these machines do allow witnessing in many cases. So you could, for at least a neuromuscular blocker or maybe another drug you want to designate, and you really want to limit this because it takes away one nurse from other things that he or she is doing, require a witness at the cabinet for what is being removed, an independent double check. Next slide. I don't think that happened in this particular case. Also, distraction-free ADC, drug removal. And you can see what I mean about these downstream incident issues being more difficult. I mean, it's very difficult to not be distracted at all. But individually, as practitioners, yes, you should endeavor to do that and not talk while you're removing drugs. Me telling you should be careful, not a very high level strategy, but think about that. And then also monitoring overrides. Pharmacy, you need to be looking at overrides on a regular basis. Who overrode? Where was it done? What was taken out? Does it need to be there? There are lots of questions that need to be asked. Next slide. And for cabinet vendors, I love that you both came forward, the big ones, Omnicell and BD Pixis. Thank you for doing that for the letter characters. We want you all to have the cabinetry and the software to be able to do that. For overrides, we want you to be able to alert users to generic and brand name searches. And for the drug information vendors, let's get rid of these brand names that no longer exist and do it sooner than we have in the past. I think that kind of thing could help prevent what we saw in this case. There are just so many things that could have been done that I don't think people were really made aware of in this case. Next slide. At the jury trial. Next slide. And then the 5 rights. I just heard this again and again, and this is next to my last slide. This really bothered me. We started writing about this in 1998, I believe it was. Right time, right patient, right drug, right. Nurses, you teach this in nursing school, and I understand why you do that, and I'm fine with that. But it is not incumbent upon a single nurse to, by themselves, know every single latent failure that's sitting out there, that where something might be sent to them incorrectly, where 2 drugs look alike that are sitting in a cabinet or on a shelf somewhere, where God knows how many things that are problematic in the system have more or less set people up to make these errors. So please, next slide, take this into account. The focus of the 5 rights is on individual performance, but the responsibility for accurate drug administration lies with multiple individuals and reliable systems, even going back to our educational process, even going to the boards of nursing and pharmacy and medicine that allow some things to go on that shouldn't be happening out there, to our staffing patterns, to the situation that we're in now with COVID-19. I could go on and on, but we don't have the time. It is not all up to one nurse, and yet the jury heard that again and again. The 5 rights are goals for safe medication practice. They do not themselves provide procedural guidance on how to achieve them. Many errors, including lethal errors, that I pointed out several times today, have occurred even where situations existed where the nurse thought they followed the 5 rights. And without adequate systems in place, we're going to continue to see this. So I hope everybody takes into account those first 2 articles, and the 5 rights do not consider the significant contribution of human factors. The environment that we work on, the noise, the interruptions, our eyesight, our hearing, our distractions, and on and on and on. We need the council of human factors experts. And that's something that we do at Ismp and our affiliate ECRI. We have human factors folks that are engaged in these patient safety efforts. And I'll stop with that. And we do have a couple of slides next with the references for articles that I referred to. Thank you. Let me pass this on to Dave Marks now.
All right, Michael, thank you so much. We are going to move into another section here. We're going to spend a little bit of time talking about sort of an engineering look at preventing wrong drug, and then ultimately talk about the justice piece. I'm going to bring and invite Barbara Olson back in to join me in this section where we can have both a nurse leader, Barbara, and myself as an engineer talk about the engineering piece of this. Also, I do want to express our thanks on the part of the Just Culture Company and the long relationship we've had with Ismp, and particularly Judy Smetzer and Michael Cohen, who have been doing amazing work over a long period of time to help make medication safety, keep improving medication safety, and the team at Ismp. And lastly, I just wanted to send a thank you out to nurses. In the light of what's happened here with Redonda Vaught, that all the nurses out there who are a part of this call, thank you so very much for your service. As even though, like me, you are inescapably fallible human beings, but yet you dedicate your life to service of others. And on behalf of my wife, my children, and me, I want to thank you for that service. So Barbara, you are on the call. Can I hear you?
Yes, yeah, you can, David, I think. Yeah, so I just want to thank you for inviting me back to provide a little bit of context for this short look at how you, as a system engineer, I know you're going to put on your attorney hat in a few minutes, but really, to kind of let us peek under the hood and see how a system can be engineered to deliver an intended outcome and how that can be quantified. I will tell you, as you know, I was a very seasoned nurse when I first came upon this kind of modeling, and it blew me away. And as I think about how many leaders have to make decisions about where to invest and put their chips, if you will, when they are trying to design a system and monitor a system, I think there is nothing like a quantitative evaluation of the relative strengths of various barriers and risk reduction strategies. There isn't anything more valuable for us right now. So I want to kind of get out of the way, but I'm going to poke and ask questions as you go forward. So thank you for having me.
All right. Well, all right. So we'll go to the next slide. And I'm going to put my engineering hat on here and talk about the general safeguards for preventing wrong drug, either by a selection error, a retrieval error, or even in the case of an automated dispensing system, a pharmacy stocking error. So if you look across this line here, I'm going to explain a little bit of the numbers, or let me start with the blue and the green boxes. So the idea here is, as I think Michael talked about, sort of robustness of the system and layers, and James Reason will call slices in the Swiss cheese. But some initial error is going to occur, and it would be that selection error. And I think if you heard Michael's presentation, there's 1,000 ways we can make that first selection error, 1,000 ways we can get to a dispensing system misstocked. And then subsequent to that downstream there's that first visual confirmation. And then downstream of that, there is a second confirmation at bedside, and then ultimately barcode scanning, which is the next item. And those 4 things all have to simultaneously fail. If I make a selection error, but I catch it at the visual confirmation, it stops that trajectory. If even I miss it by error, and I put rates in here. The 0.001 is the 1 in 1,000 rate. That's not, at least in terms of modeling perspective, a reasonable place to start, to say, look, 1 out of 1,000 times I'm going to get that selection error. Then I have to make a mistake in my visual confirmation. I have to make a mistake in the visual confirmation at bedside. And then that downstream 0.0001 is the reliability of barcode scan at bedside. And so, and then to the further right is the post-administration monitoring, at least to mitigate, if we've already given the wrong drug, what is the likelihood of that occurring. But if you look across this line here, and it is the next square, it's going to pop up. The rate, if all these things occur, that I have to have a selection error, I have to have a visual confirmation error actually occur twice, and the barcode scan has to fail, we're in the neighborhood of what engineers say 1 times 10 minus 13th, or 1 error that got to the patient every 10 trillion doses. So this is an amazing system, even where all 4 errors have to occur simultaneously. Next block. So what we want to talk about now, and Barbara talked about this notion of at-risk behavior, where we're going to have a visual confirmation, and rather than do it every time, we drift into a bit of at-risk behavior. And part of that drift is, part of that recipe for drift is that I know downstream, if I don't catch it here, I'm going to catch it later. At bedside, the barcode scannings work for a variety of reasons. What will happen is what was a 1 in 1,000 error rate turns into a failure rate of 1. And that's because we're no longer doing that particular activity. And part of the reason for showing this is we're going to get you to where we think redundant was, or what the event details describe as redundant sort of place and operating place of this. So if that goes to a 1, then the next block here is the rate now turns into, rather than 1 in 10 trillion, we're down into about a 1 in a billion. So I had these 4 blocks, the 4 errors that had to occur to prevent the wrong dose. Now I'm down to 3 because I'm no longer doing that visual confirmation at the dispensing system. So if you go 1 step further, we go to the next line, and all of a sudden we see a second at-risk behavior. And we can talk about this in the justice model, whether it's at risk or whether it's reckless, but we now have this second confirmation not occurring. So I have to always make a selection error because I'm always having to get the drug. You're not going to have the wrong drug to patient unless there's some selection of a drug in the first place. So that first error, the 0.001, is going to occur. Now there's 2 downstream behaviors that aren't occurring. So their failure rate is 1. And then we get to the barcode scan at bedside, the 0.001. Even with those 2 confirmations not occurring, the selection error combined with a barcode scan at bedside error, that gets us to the neighborhood of 1 in 10 million doses. Now, Barbara, you wanted to say something at this point.
I did, because I just wanted to make sure that I was understanding this correctly, because I'm looking at this and thinking, well, this is kind of your worst case scenario where someone who is drifted or for whatever reason doesn't do the visual check at the point of retrieval, doesn't do the visual check at the point of administration, but is in a place where barcode medication technology is in place, and let's also put into their well-managed, used as designed, and so forth. At that point, the fact that somebody hasn't done their human duty there, I, as a patient, I'm still sitting there with a 1 in 10 million chance of getting the correct dose, or only a 1 in 10 million of getting the wrong dose. Am I right when I think of it that way?
That's right. And many of the mechanisms that Michael talked about in the front end, can you take that initial selection error and even reduce the rate? And that's where a lot of the human factors design is. Let's keep reducing the rate. Let's not have that error occur in the first place by forcing functions, by barriers. There's a lot you could do in that first column to say, look, let's just reduce the rate of the error. But then secondly, the barcode scan, at least in an administration, for the selection retrieval or pharmacy stocking error, that barcode scan is an amazing tool. And typically, you don't drift around the barcode scan because the barcode scan becomes part of the medication administration process to do the job. It helps you. It helps you record that the drug is being administered. There's a lot that barcode scanning is a part of a process of. So just those two, as you said, Barbara, gets us to that 1 in 10 million. Now, the next one, the next line here is, okay, what if the hospital, and perhaps a little at-risk or maybe even reckless behavior on the part of a hospital, says, we're not going to use barcode scanning, or we're going to use it through a lot of the hospital, but in particular areas, we're not going to use it, which to some extent is a little bit of the setup, because if you get used to having barcode scanning and you're now no longer doing this visual confirmation because, oh, I got the barcode scanning downstream, and now all of a sudden that barcode scanning isn't there, you have to catch yourself to say, hey, wait a second, I really got to make sure I get that visual confirmation done. But if you take the two confirmations out and the barcode scan, now we're down in that sort of real red zone where all it takes is the selection error ultimately. And now we're down that zone of 1 in 1,000 rate of error. And now we went from 1 in 10 trillion down to a 1 in 1,000 because 3 pieces of the puzzle are now missing in action. The next slide, next. So the next line is ultimately where Redonda Vault was. And actually, if you click sort of 2 buttons here, you got all 3 ones, you got no mitigation, and then the next visual here. This is the Charlene Murphy event. There was an initial selection error, whatever likelihood of that occurring there was. There was a visual confirmation that wasn't done. The failure rate, at least on this day, was 1. If you don't look at the drug, you don't visually confirm it, you're not going to see it. If you don't confirm it at bedside, if you don't have barcode scan at bedside, and then even no mitigation, this is the place ultimately where Charlene Murphy, ultimately that led to the loss of Charlene Murphy's life. This is perhaps the place that Redonda Vault was operating. And the question is this the place in which Redonda Vault routinely operated? Is this the place in which other nurses in similar circumstances at Vanderbilt routinely operated? Or even in your hospital, if you're on the call, when do you operate in this mode? When are you not up at the 1 in 10 trillion, but you're down to 1 in 1,000 because of either at-risk behavior or because we've made decisions not to have things like barcode scanning at bedside available in certain circumstances? So Barbara, what else would you like to say on this slide?
No, it's really helpful, David, I think, to see that quantified that way, because what occurs to me is, when you're talking about a 1 in 1,000 likelihood of something undesirable happening, I've got to believe in busy units that you would have events, right? And I want to just call out here, we know about this tragic event because the medication that Redonda took in error was one that had the potential to kill the patient, right? Yeah. I wonder, in 1 in 1,000 environments, how many times people realize their patient did not get the intended drug, but they simply aren't able to detect it because it did not cause clinical harm. So I just want to throw that out and thank you for the modeling, and also, invite you to go on, because I know people are eager to hear more about justice and putting on that lens.
Yeah, and Barbara, one of the things that the reason you and I wanted to show this slide is a lot of what happened in this event when you talk about Redonda Vault's behavior is she made an error in selection. In part, you might say an at-risk behavior of the override, but I'll let you evaluate that as the domain expert, whether what that was. But there was the lack of a visual confirmation, both at the ADC and the bedside. And there was the no post-administration monitoring. So a lot of the elements that we'll get into the justice evaluation really come out of Redonda Vault's operating down in this lower line here. So to the next page, I'm going to take off my engineering hat and put on my lawyer hat as we go forward and talk about the firing, the revocation, and the criminal conviction of Redonda Vault. So next slide. There is a lot of confusion about what the criminal law does and doesn't do, even in terms of its motives. It's not about retribution. It's principally around deterrence. But I'm gonna spend a little bit of time talking about the criminal justice system and how ultimately we can think about this in the context of Redonda Vault's criminal conviction. So I'm gonna start off on the right-hand side. We talk about in the criminal law really 4 levels of culpability, and this is right out of the model penal code. that many of the states in the US have patterned their criminal justice system off of. So on the far right-hand side is the notion of a purpose to cause harm. And this would be like bullying or assault or murder. And clearly we say, okay, that puts you in the bucket where sanction is coming your way. And if it's toward physical harm, jail is probably coming your way. The next one to the left, knowledge, is knowingly causing harm. This is theft. It is going into George Clooney's medical record, a HIPAA violation, where it's not my goal to cause harm. It's just sort of a me first. I don't mean to diss George Clooney. I just want to see what his record looks like. That's knowingly causing harm, and that ultimately gets us into sanction. The next one is reckless. Reckless is what you know and I know is reckless driving on the road. Drunk driving is the quintessential reckless behavior. You might refer to it as gambling, and ultimately say, look, if you are going to knowingly take risks that you see as substantial and unjustifiable, we're going to come after you. And that becomes the reckless behavior. The problematic one is this one on the left that we call negligence. And negligence in the criminal law is a more recent construct in human history. It's only the last 200 years that we've really had this notion of criminal negligence, and we're gonna ultimately see sort of where it leads us on this journey. But the negligence is really should have been aware, but was unaware of the same substantial and unjustifiable risk that the reckless person has taken. If I see it and I consciously disregard it, it's in my theater of consciousness. I see it, I have to say to myself, yes, but due to my own pursuit of happiness, whatever motive, I'm going to do that. That's reckless. Negligence is should have been aware of a substantial unjustifiable risk. And this is where we get to criminalizing human error. And when we talk about criminalizing medical error, it's not a unique issue to medicine. We've been criminalizing human error for 200 years. If you look at the statistics, about 200,000 people are inadvertently killed each year in the US, not including any number close to like the 440,000 we would say in healthcare due to medical error, but just sort of everyday street stuff, home stuff, 200,000. Let's say half of those are killing somebody else because we inadvertently kill ourselves once in a while, like an automobile accident. Well, in the US, roughly about 1,000 of those, 100,000, will lead to a conviction for criminal negligence. And that's about a 1 in 100 rate, all right? And it could be anything from the parent who inadvertently leaves their kid, in the back seat, forgetting to drop them at daycare, which we see routinely in America. It could be a driver who falls asleep, like Tiger Woods barreling down the road in California. It could be a police officer like Kim Potter in Minneapolis who screams taser, 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 and thinking she has a taser in hand, ends up shooting Dante Wright with a gun and then gets prosecuted and spends sentenced to 2 years in prison. So this notion of criminal negligence is not new. It's not dedicated to healthcare. It is what's happened in the last 200 years. We've raised the bar to be a highly reliable society, we have gone from recklessness as the floor of the criminal law to negligence now being the floor. So next bar to show up here. So one of the things about negligence is we can't put in jail everybody who's negligent because all of us would end up in jail. So what the criminal law says, well, we're gonna have a bit of grace here. As long as you don't kill anybody along the way, it won't be a crime. But if you make a mistake that kills another human being, now you expose yourself to criminal negligence. Next slide. On the right-hand side, reckless knowledge of purpose, those are so culpable that we're willing to say, hey, wait, we're not gonna wait for harm to occur. Mothers against drunk driving are had right. It's not mothers against drunk drivers who kill, it's mothers against drunk driving. So for reckless knowledge of purpose, we said all you gotta really is have that intention towards some significant harm. But there is a very strong severity bias. If you look at your laws around drunk driving, the severity of harm is what really pushes you into that space. Next slide. And then clearly what happens in our current criminal law is it's not really about learning. It's not much of a learning system at all. We're just sort of judging, and we're using the criminal law as a deterrent for people not to engage in any of these 4 behaviors. Next page. So we're going to look at for what the people of Tennessee in particular did and what Redundant Vaught was prosecuted under. So next block here. So there's 2 things that people in Tennessee did to say, look, if you're a citizen in the state of Tennessee, you got to be accountable for your actions. And one of those is what we call recklessness. Recklessness is that conscious disregard. And so, all right, if you're reckless, if you're weaving lanes in and out, doing 110 miles an hour on the highway, well, if you don't cause harm, but we catch you, it's less than a year in jail. If you kill somebody, it's 2 to 12 years in jail. That's recklessness. Compare that to the next block here, which is negligence. Negligence, as we just talked about, is where a person ought to be aware of a substantial unjustifiable risk. With no harm, it's not a crime. When death occurs, it's 1 to 6 years in prison. Now, so what are the people of Tennessee saying? Next block shown here. The people of Tennessee are saying, look, we got 2 issues here. Don't be reckless, and then don't kill another person by mistake. When they prosecuted Redundant Vaught, the jury said, we do not find Redundant Vaught to be reckless. We did not find that, but they convicted her of the lesser offense, which is that of negligence. And for every nurse on the call, if you are at a dispensing system, you've grabbed the wrong drug, and you're walking down the hallway with the wrong drug in your hand, heading toward your patient's bed, and let me ask the question, should you or ought you have been aware of a substantial unjustifiable risk that you may give that med to the patient? Ought to have been aware is a very low floor. Much of our life activity, running a red light and narrowly missing somebody, it's easy to say ought to have been aware. Next page. So our model of just culture, as we speak about just culture, we try to take negligence out of the picture and we replace it with human error and at-risk behavior. Human errors are things I never intended to do. We say, look, we don't choose these, they happen to us, they're unintended conducts. We say, accept the error, live with the error and learn from it, because our belief is the learning culture can produce a better result than having a punitive culture where everybody hides their mistakes. The second one on the block on the left is at-risk behavior, and Barbara's talk about this. At-risk behavior is all those choices we engage in, whether it's on the road, not signaling lane changes or speeding on the road, or in a healthcare system where we don't wash hands leaving the patient's room, or we don't do 2 patient identifiers because I already know who my patient is. There's a lot of at-risk behavior. Both of those occur in mass in society as a whole and in healthcare in particular. And the idea is we can learn more out of the human error and at-risk behavior, and then we're going to get out of sanctioning it and causing both of those behaviors, human error, to go underground. Next slide. Additionally, what we say is forget the severity bias. Reject the idea of no harm, no foul. Don't wait for harm to occur. All right, monitor what's going on and ultimately hold people accountable for the quality of their actions. So don't give a pass to the reckless driver or the reckless doctor or nurse simply because they haven't caused harm. We do all of this independent of outcome. And next block, the idea here is that we learn from them all. Next page. The fundamental disconnect here, and actually you can click on both next 2 here. Yes, the fundamental disconnect is patient safety specialists, and in the over 20 years here I've been spending time hanging out in healthcare, is patient safety specialists use the word human error, use the word medical error, medication error, and if they're sophisticated, they adopt the language of at-risk behavior. All right, but those are being used to describe what human resource leaders and the legal system sees as negligence. They are one and the same. All right, we're looking at Redundant Vaught and saying, wow, how could she be convicted of negligence? And the answer is because it was easy. Should she have been aware that what was in her hand was substantial and just risk of harm? The answer is yes. The question isn't, was she negligence? The question is there any reason to criminally prosecute the person who engaged in a human error or at-risk behavior? Already, the criminal court said we didn't find her to be reckless. So under our just culture model, there would have been no disciplinary, if you believe that, the jury, no disciplinary action, no license suspension, and no criminal conviction. But if you want to go after negligence, then all three are going to apply. She gets fired, she loses her license, and she goes to jail. Part of what we have to reconcile in healthcare is we have to not see negligence, human error and at risk, is three different things. It is we have to understand that negligence in the law is a very low bar. All right, there's a lot of negligence. And again, go back to Kim Potter, taser, 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 total human error. She's now spending 2 years in jail because by that human error, by having the wrong thing in her hand, which is pretty similar to Redonda Vaught, except she had a gun rather than a taser. All right, Redonda Vaught had vecuronium rather than Versed. In our society as a whole, we have criminalized negligence. And by doing so, we have criminalized human error and at-risk behavior. Next page. So where does this get us? And you can show both of the blocks here, or all three. Just watching the time here. So this is from One Hospital's Just Culture Policy. And I would ask you guys to sort of think about this in your own organizations. So the patient safety person on the left-hand side saying, wait, blaming individuals creates this culture of fear. We don't need that. We need people to raise their hand and say, I made a mistake. We need to be able to learn. But in the same policy, they write the right-hand side, which is when there's incompetence or substandard performance, all right? When there's recklessness, that's okay. A willful violation of policy or negligent behavior. That negligent behavior is the human error and at risk. We may use corrective action or disciplinary action. We're struggling with a common language. We got to get the word criminal, we got to get the word negligence out of this kind of justice model. And we have to be able to talk about human error and at-risk behavior. The willful violation, this is a tough one because did Redonda Vaught willfully violate the protocol at the ADC and at bedside? And do you willfully violate a policy when we're not washing hands at a near 100% rate of compliance, or we're not doing two patient identifiers? The reality of it is, and as Barbara talked about, there's a lot of at-risk behavior in healthcare. And ultimately, the issue is we have to be able to admit to it. We have to say, look, people deviate from procedure to some extent as much as they do on the roadways when our kids are in the backseat of the car. Ultimately, we have to learn from it. We have to monitor it, and we have to coach people back onto the safe path. We have to get past this fundamental disconnect that sort of separates negligence and human error, because ultimately they're one and the same. And ultimately, we have to take negligence off the board and not turn that into a crime. Next page. So what can you do as leaders? And we're just going to go through these real fast, and then we're going to, I think, open it up to questions and answers. But first one, redesign the system. All the stuff that Michael talked about, all those interventions, the first and best thing we could do, even for both nurses, for providers, and for patients, is to prevent harm in the first place. That's the first thing we do. There's a lot that we can do to do that. Number two is share the root cause analysis. When at the point that your nurse is going to be criminally prosecuted, perhaps that's the time where you as an institution come out to the world and say, look, here's our root cause analysis. Here's not only what our nurse did, but here's what was in our nurse's head, what the nurse was seeing. Here's what other nurses do. Here are our behavioral norms. Here's the quality of our system design. But come out and say, do a good RCA and share that RCA. Number three, revise your disciplinary policies. Ultimately, don't make everything against the rules. Don't make everything misconduct, but say, look, short of reckless behavior, in order to carve out the human error and the at-risk behaviors that even the criminal jury here said Redonda Vaught engaged in, she wasn't reckless. They didn't find her to be reckless. Anything short of reckless, we're going to guarantee to our employee by policy that we're not going to discipline you. And we're going to do this regardless of the severity of outcome. That's the place we need to be. And then the last one here is get professional boards, regulators, and the press on board before we have the event. If we want to continue to make healthcare safer and safer, the professional boards, the regulators, the press, it's not about skewering the person who's made a mistake. It's not that severity bias. It's getting those organizations on board so they can be a part of the process. So with that, Judy, I will turn it back over to you.
Yes, thank you, Barb, Mike, and David for your thought-provoking presentations. In closing, I'd like everyone to remember that Charlene Murphy lost her life due to this error, and our sincere condolences go out to the family for their loss. This was such a tragic error. And as David said, we want to thank all the nurses who take care of patients in healthcare. We know it's a very scary and tough job, and we celebrate nurses, especially during the month of May, which is Nurses Month. So we have a couple polling questions on the screen. If you take a few moments to answer them, that would be much appreciated. There's actually 4 questions, so you might want to pull down. It looks like most people believe that they want to redesign their medication use process. They want to conduct better root cause analysis. They want to revise their disciplinary processes, and they feel it's necessary to engage the professional boards, regulators, and press. Now, I'd like to remind our participants that you can ask a question by opening the Q&A icon at the bottom of the toolbar. We have a couple questions. We have quite a few questions that are already have already been submitted, and we're not going to get to all of them. But let me ask just a few. Mike, you covered a lot of strategies to reduce the risk of similar errors in other facilities. What would you say are the top 3 high leverage risk reduction strategies?
I think I'd probably say limiting access to the neuromuscular blockers, just like we did with KCL. It was very, very effective when it was taken off the nursing units. I'm not saying that it isn't needed in some locations, as I mentioned before, but there are places where it presently is located that maybe it shouldn't be located, obviously. And then also by limiting access, I always mean packaging it in a way like the kit idea, the bags, having pharmacy bring it, having an anesthesiologist bring it when a patient has to be intubated, things like that, if it's in the inpatient area. And I think barcoding, that's downstream, but it needs to be considered upstream. It really needs to be hospital-wide at this point. And then probably I would go with the 5-letter characters as well. I'm really worried about that because truly we are seeing more errors now than we did with handwriting. When the handwriting was bad, you had to call the doc or the prescriber and ask what was written. It was when things started to look alike, 2 names that looked alike, that it was a problem. That was pretty rare. Now we're seeing, 2 different drugs on the screen with the same strength, and people are selecting the wrong one. I think you need to type in at least 5-letter characters. That takes care of, the vast majority of medication mix-ups, I would think.
Okay, and then a question for David. Most people understand human error and the need to avoid disciplinary sanction for inadvertent human fallibility. But how do leaders clearly distinguish between at-risk behavior and reckless behavior when an employee consciously disregards or bypasses an important policy or procedure?
Yeah, that's a good question, Judy. And, and for a long time, you have been, as you've been looking at records, you just really begin to appreciate to some extent just how much at-risk behavior there really is. And, as a leadership team or those who are going to stand the judgment, you're going to ask that question, did they think they were in a safe place, or inside their head is that sort of internal risk monitor going off? Is it alerting them to them being reckless? Part of the reason you look beyond the individual involved, you look at what peers are doing, what risks they see, and you try as best you can to sort of model and say, what is likely going on here. If it's not confirming drugs coming out of the dispensing system, most often that's probably going to be an at-risk behavior, particularly if you start to see it as a norm. So it's just working your way sort of through the just culture sort of definitions that can get you to that separation of at-risk and reckless. But clearly, and I think you've seen this, Judy, is you can't believe that at-risk behaviors are rare. They are ever present in every aspect of society. We're not really rule followers as human beings. We're sort of hazard and threat avoiders. And as the more you understand about human behavior, the more you start to appreciate the circumstances that drive at-risk behavior, where you're likely to see them, and then ultimately in the just culture model, how you're going to stand in judgment of those.
Yes, I agree. And I just want to add that for at-risk behaviors, it's the conscious disregard of that risk rather than the just disregard of a policy or a procedure. So
Yeah, for reckless, right.
right. So we're yes. So we're looking at the risk as opposed to the regard of the policy.
And maybe, you know, the clarification on my answer there, Judy, is yeah, does a person choose to deviate from the rule? It's like speeding on the road when you merge in 10 miles an hour over the speed limit. Do you know where you're doing it? The answer is yes. If the question is, did you consciously violate a rule? Most at-risk behaviors involve a conscious, you know, at least a knowing violation of the rules, but still believing they're in a safe place.
Right. Okay, and then the last question goes to Barb, and most of the questions were related to Redonda's error. So I'm going to give you 3 in a row. Is it true that Redonda gave the same patient Versed for the same indication the day prior to the event? And were both the generic and brand name included in the order? And what was the standard warning for meds that meds were taken for override?
Yeah, and those are all great and important questions. And unfortunately, it's information that is just not known to us. There's a lot of detail in the video from the Tennessee Board of Nursing hearing, which is streamed. But the answer to the first 2 questions, I can't get to, you know, through what's available to me. But I love that you're asking, because if you were doing the root cause analysis and, you know, really running this to ground, it's information that you would want to know. And do you say the third one again?
Well, the third one had to do with what the standard warning was when there was a standard warning on the screen on the ADC.
Yeah, and I can't speak to it directly, other than what I do know is it basically said, you're taking a drug on override, this should be for a stat reason. I believe that there is a, you know, with some kind of interactive thing from a drop down where an individual would put that in. I mentioned it simply because, you know, if overrides are common or endorsed, then whatever kind of flag is going on there isn't going to draw any particular attention to the fact that, hey, you might have a neuromuscular blocking agent in your hand. It was the simple, a standard, this is an override, please acknowledge it. Are you sure you want to do it?
Right, and then that takes me to the last question, and anyone can answer it. Has Vanderbilt made the necessary changes in their policies to avoid a similar event going forward? Well, I'll start answering. I think they're now using shrink wrap for their neuromuscular blockers. They now have midazolam on their high alert medication list. They now have procedures to monitor patients who receive IV midazolam. They did not have procedures previously. They've looked at their anxiolytics prescribed for claustrophobia in radiology because it was certainly an emergency. Charlene had already gotten her tracer, and so they were going to cancel the procedure if they didn't give her the anxiolytics. So that's probably why they went right away to the IV. But they looked at their anxiolytics that they're prescribing for claustrophobia in radiology. They're more closely monitoring overrides. They do now have warnings on the ADC screens that are specific to neuromuscular blockers. It was very specific to overrides, but not specific to neuromuscular blockers. So it asks people to confirm that the patient is on a ventilator or being intubated. And then finally, they wrote an action plan for CMS that was accepted. So I'm assuming that there are more strategies that they put in place that we don't know about. Anyone else have anything to add? Well, I'm very sorry if we didn't get to your questions. We have exceeded our target of 2:30. And our webinar is now over. Thanks again for joining us today, and we appreciate everyone who participated. Thank you.